Welcome to No Filter Doctor, where we cut through the health hype and dig into what's real, what works, and what's backed by evidence. I'm Dr. AK. Let's get into it. Hey everyone, welcome back. Today, we are talking cholesterol. I know the excitement is overwhelming. I can feel it through the airwaves from all of you. But here's the thing. We're not going to talk about basic cholesterol information. There is more to cholesterol than kind of this caveman mindset that we have, like LDL, bad, HDL, good. And then you want to hit something with a club. So there are other lipid particles that we need to know about. There's some things about atherogenesis that we need to discuss. And then, of course, we need to talk about, well, what can you do to optimize your cholesterol? And you might be saying, hey, AK, you've already talked about cholesterol. And I'm going to tell you, yes, I did. But I received a lovely message from one of you asking me some additional questions about cholesterol and lipids and what all of it means, because it is confusing. And so when I thought about it, I'm like, I did talk about cholesterol, but I think we need to break it down in a different way and talk about some of these other particles, because a lot of the questions were with these other particles. And so that is what inspired today's podcast. Let's start with some simple definitions. When we look at our lab tests that our doctors get for us, we will see cholesterol, and there's various forms on there with different letters that usually end in DL. And then there's triglycerides. So I want to talk about what is the difference between cholesterol and triglycerides. They are both fat molecules, but they are very different in structure and function. When it comes to their structure, I am not giving you an organic chemistry lesson and describing these structures in a podcast. You can go to the blog and look at them. And that's really more of a visual thing that I want you to see how distinctly different they look, because they get confused a lot. In terms of function, cholesterol is really a building block. It serves as a maintenance of cell membrane structure. It acts as a precursor for steroid hormones like your estrogens and testosterones, in addition to vitamin D. And it's a precursor for bile acid synthesis. And so that's what is in our gallbladders. Triglycerides are an entirely different beast. They are used predominantly for energy. So they're transported to cells and then broken down through a process called lipolysis. And this allows cells to use the fatty acids that are in the triglyceride structure for energy. Now, again, they're both fat molecules, so that means they're hydrophobic. You might, when you read some scientific papers, see something about hydrophilic, hydrophobic. Hydrophobic means it does not mix well with water, and hydrophilic means it mixes great with water. Think of a salad dressing that has oil in it. You can see how they layer out. That oil is the hydrophobic layer, and the rest of the salad dressing is the hydrophilic layer. And you might say, well, why are you spending so much time talking about salad dressing? It's because your cholesterol and triglycerides cannot just freely float around in your blood, because your blood is mainly water and these are fats. And that is where another molecule comes into play, which is an apolipoprotein. This is a structure that kind of wraps around the cholesterol and triglycerides so that they can be packaged, and then that complex together, the apolipoprotein with the cholesterol and triglycerides, is called a lipoprotein particle. Lipoprotein particles can travel around through the blood. So that's how your body kind of deals with the fact that these fats have to get delivered to target structures. So it creates a lipoprotein. And if you want a visual of this, picture a tennis ball. This is an oversimplified example, but for you to understand kind of visually what this looks like. In our tennis ball model, the core of that tennis ball is going to be some kind of combination of cholesterol and triglyceride. The outside, that green felty part, is where our apolipoprotein is. I mean, there are other things too. There are like phospholipids and these other things, but we don't need to get into all of that. For the purpose of this example, the apolipoprotein is the green felty part, and then the cholesterol and triglyceride are the core. The two main apolipoproteins that are that green felty part on the tennis ball are apolipoprotein B and apolipoprotein A. And most of this packaging that we're talking about occurs in the liver. You'll eat some fats or some carbohydrates. Those foods get absorbed in the intestines. The intestine is kind of the first area that creates like this big lipoprotein. It's called a chylomicron. You don't necessarily need to know that. I'm just telling you some information here to understand the processing. That typically goes to the liver, where some additional processing is going on. And then other lipoprotein particles come from there. If I were on stage and giving a talk right now, this is where I would pause and ask the audience if anybody has questions. But unfortunately, I cannot do that on a podcast. So if you have additional questions, there are 2 blogs that I wrote about cholesterol. You are welcome to read both of them. The blog is called From Dr. AK's Desk. It's free and I get no money for it. It's just there for information. You could also send me some kind of message. This entire podcast was inspired by somebody sending me a message. So I'm going to hope that you understand. If you do not, maybe rewind and listen again. And if you still do not, send me a message. But now we're going to talk about the different lipoprotein particles. Things are going to start to sound familiar here because this is the HDL, LDL, VLDL, and all these other things that you see on your blood work. There's obviously a difference between all of them. So one of the first differences is what is the apolipoprotein that wraps around them. So they will have different, if we go back to that tennis ball model, they will have different green felt apolipoproteins. All of the ones that have apolipoprotein B are atherogenic. So let's talk about those first. There are 4 main atherogenic lipoproteins. They are VLDL, IDL, LDL, and something called Lp(a), so lipoprotein A. I talked about the chylomicron that come from the intestine and then they go to the liver. Well, one of the main particles that the liver creates is something called VLDL. Their cores typically contain more triglyceride than cholesterol. And these are the particles that the body receives for fatty acids. This is what we want for energy production at the cellular level. When the cells remove the triglyceride from VLDL, and again, it usually happens in the muscle or it can go to adipose cells, you get the formation of either IDL, which is an intermediate density lipoprotein, or LDL, which is a low density lipoprotein. The ratio of triglyceride and cholesterol can vary, but in general, IDLs still have some amount of triglyceride in them, and LDLs might have some triglyceride in them, but they really are the majority of the circulating cholesterol. Lp(a) is a very special LDL particle, if you will. So this is mainly cholesterol, and it's small. If we're going back to that tennis ball, it has the apolipoprotein B on the outside, that green part. The inside is mainly cholesterol, but then the green part has this other little molecule called apolipoprotein a, not to be confused with the other one that we mentioned, which is a big A, capital A and lowercase a. This one, Lp(a), is the lowercase a apolipoprotein. Confused yet? Probably. I don't blame you. I am not a learn through listening person. I need to sit down and see this. So I'm going to try and use this tennis ball model to explain this. All of the atherogenic lipoproteins, VLDL, IDL, LDL, and Lp(a), have apolipoprotein B as the green felty part on the outside of the tennis ball. The insides of them are going to be some ratio of triglyceride to cholesterol. That ratio determines how dense the lipoprotein is. The exception is Lp(a), which has an extra molecule on the green felty part. So those are all the atherogenic lipoproteins, which means these particles get into the blood vessels and start to cause plaque and inflammation, which are the first steps in getting atherosclerosis. The opposite of these particles is HDL, which is high-density lipoprotein. In fact, HDL can help take the cholesterol out of those blood vessels through a process called reverse cholesterol transport. So unlike the atherogenic ones, HDL is bound to apolipoprotein big A, capital A. This property that it has through the reverse cholesterol transport, where it's going in and kind of gobbling up cholesterol and taking it out of the blood vessels, is why HDL has in general been referred to as the good. I'm putting it in air quotes. I mean, it is good. I shouldn't quote it, but that's why it's been referred to as the good cholesterol. So when you have high HDL levels, the traditional thinking is, then you will have decreased plaques because this HDL can go in and pull that cholesterol out of your blood vessels. We're going to get into details about some of these things and the nuance, but that's just the basics. Those are the particles. Those are the atherogenic ones. And then we talked about HDL. And now I want to talk about labs and how these normal ranges can be a little bit misleading. The reason why the labs are a little bit misleading is because these cutoffs for normal labs are not clear and consistent. What is considered normal is based on thresholds for risk. So what does that mean? Basically, the American Heart Association and the American College of Cardiology publish guidelines, and they do this every couple years. And in those guidelines, they review the research and update things. And so they identify values that are associated with higher risk of atherosclerotic cardiovascular disease. So what is considered normal is really up to those values where we have learned, oh, if you are at this level or higher, then you're at risk for ASCVD, which is what I'm going to say now rather than atherosclerotic cardiovascular disease, because for whatever reason, atherosclerotic is very hard for me to say. So the other challenge is that those values can also change depending on someone's burden of existing disease. For example, in 2018, the AHA-ACC guidelines identified an LDL greater than 160, ApoB greater than 130, triglycerides greater than 200, and LPA greater than 50 milligrams per deciliter or 125 nanomoles per liter as higher risk for ASCVD. An earlier guideline recommended LDL less than 70 for patients at high risk and less than 100 for everyone else. So we have these values that the 2018 guidelines said if you're greater than these different things that I just rattled off, you're high risk. But based on earlier recommendations, LDL is actually not that simple. It has to do with whether you're high risk or not. Because if you're high risk, you should be less than 70. If you aren't, you should be less than 100. There is no mention of what total cholesterol value should be or what a VLDL should be. And that's something that, is reported on a lot of our labs. But then if you use the LabCorp, and I don't have any stock or anything with the LabCorp, they were just, the rep was easier for me to get a hold of. And so I have an account with them and I'm able to access this information easier. LabCorp uses different reference ranges. For Lp(a), they say less than 75 nanomoles per liter. But the guidelines said 125 nanomoles per liter when it came to Lp(a). Total cholesterol, they say less than 200. Total cholesterol isn't listed anywhere. Triglycerides, they say less than 150, even though the guidelines said if you're greater than 200, that's bad. For HDL, their reference range for normal is greater than 40 for everybody even though we know men greater than 40 is the value we're going for and women greater than 50, again, based on the guidelines. So things are a little bit all over the map when it comes to normal ranges. Then if you add to that someone who has a family history or someone who has diabetes or high blood pressure, then all of these values change again. So it can be very confusing when you are looking at your blood work to figure out, well, what here is normal? What's abnormal? What am I supposed to worry about? What am I not supposed to worry about? And I know that people are able to speak with the person who ordered the script for those labs, but at the same time, sometimes doctors aren't always available or people on their staff isn't always available. And some of us really do want to learn this so that we can understand it and kind of be on top of our own health. Well, when you have these labs in terms of what guidelines are saying and then what reference ranges are, none of them are the same. It's very confusing. The other thing that's confusing is these other lipoprotein particles that we talked about, there's more to it than just LDL being atherogenic, right? I mentioned some of these other ones, but we've learned a lot more in terms of what these other ones mean. We've also learned more in terms of what should we be getting labs on. An example of this is apolipoprotein B. We talked about how it is the green felty part of the tennis ball for the atherogenic particles. Not only does it allow those fat particles to go through our bloodstream, but apolipoprotein B has a molecule on it that allows it to bind to the insides of the arterial walls. So apolipoprotein B allows the fats to circulate to our blood. It then is able to get through the blood vessel walls, and then once it's there, it can bind within those blood vessel walls. And although we lean heavily into LDL, those other particles that have ApoB as their apolipoprotein, they are also atherogenic and they can do what I just described. The reason why we focus on LDL as opposed to the other particles is because there's just so much more LDL than those other particles. This is really just a statistics and probability thing. If you have so much more of a certain particle that is atherogenic and that particle is high, that is a good marker of your overall risk when we're talking about cholesterol. But it is an incomplete picture of what is happening with the lipids. And the reason for this is because ApoB particles can have a variable amount of cholesterol in them. So when we talked about each of those atherogenic particles, we talked about how they're different proportions of triglyceride and cholesterol. Well, sometimes there is a discordance. That means someone may have an average ApoB level, but really high cholesterol. Another person may have a high ApoB level and low cholesterol. That's called discordance. And when you are looking at discordant groups with high cholesterol but low ApoB, cholesterol predicts whether they're high risk or not, and then the ApoB will say they're low risk. And in groups with low cholesterol but high ApoB, the reverse is the case, right? So you're like, oh, they have low cholesterol, they're low risk. But no, the fact is, if their ApoB is high, they're high risk. And what we've learned is in these groups where there's a discordance, looking at that ApoB particle is a more accurate marker of cardiovascular disease risk than looking at cholesterol. The analogy that I explain to my patients is a cab and a passenger. So if we say ApoB is the cab and cholesterol is the passengers, when you have a lot of ApoB, that means you have a whole lot of cabs that are driving around. When the cholesterol is low, that means that those cabs just have a low number of cholesterol in them. That's concerning because it implies that there are a whole lot of these small particles, and small particles get into blood vessel walls a lot easier than big particles do. The big particles can get in there, and because they are carrying bigger amounts of cholesterol, they can cause more inflammation. Like that one particle can cause more inflammation than one tiny small particle. But when you have a whole bunch of tiny small particles, more of them get into the blood vessel wall and cause inflammation and plaque. That's one scenario. But the other scenario is there are passengers that are unaccounted for. These passengers typically are the VLDL and LDL when we have cholesterol lab values. What we don't tend to measure are those intermediate density lipoproteins. So when you have, again, high ApoB, so a lot of carbs, but your cholesterol is low, that also could imply that there are a whole lot of carbs driving around with passengers that we don't know about. Specifically, those intermediate density lipoproteins, which also happen to be more atherogenic than LDL. Again, the reason we focus on LDL is because there is so much more LDL circulating in our blood. But these other particles, like the IDLs, they are super atherogenic and we don't typically measure them. While the number of passengers is important, the number of carbs is a more accurate marker of what is going on in our bloodstreams. Another particle that is not typically measured is the Lp(a), which happens to be 6 times more atherogenic than the LDL particles. And this is because they have a high concentration of what's called oxidized phospholipids. And all you really need to know about that is oxidized phospholipids increase the expression of certain molecules that like to bind to arterial walls. So you have your apolipoprotein B, which allows this particle to float through the blood. Then it gets the particle into the blood vessel wall. But then this Lp(a), it's like a super binder of inside the arterial wall. And the other thing about this Lp(a) is that it is genetic. So there is very little variability of this over time. It's also associated with another condition called aortic stenosis. We don't measure Lp(a). So again, you could have a high apoprotein B and kind of a lower cholesterol, which is how I was most of my life. And then I got an Lp(a), and I found out that my Lp(a) is 183 nanomoles per liter. If you remember, the cutoff value was 75. Less than 75 is supposed to be normal. So I've been floating around with this Lp(a) my entire life with really normal cholesterol until recently. Again, that cholesterol picture in it of itself, the cholesterol that we get without measuring ApoB or measuring Lp(a) is an incomplete picture of what is actually going on with our lipid profile. The other thing that we need to know in terms of ASCVD risk is HDL function versus HDL levels. So we talked about those HDL levels, and if they're above 40 for men, that's great. And if they're above 50 for women, that's great. But we're now starting to learn that there's more to it than just that number. So we want to know, how well is the reverse cholesterol transport system working? It's kind of like, great, you have high HDL, but how well is that HDL functioning? And so there are several studies that have demonstrated HDL function is a better predictor of cardiovascular disease than just HDL. And the problem here is there are no approved assays for routine clinical use. They have certain function tests that they do in a lot of different research studies, but we don't have anything that we can measure on ourselves in a clinical setting to see, okay, so my HDL is a good number, but how well is it functioning? So for now, this HDL level we're using as a surrogate. We're just kind of assuming if we have a higher HDL, we are hoping that that means that our total ASCVD risk is lower because that HDL is functioning properly as well. So, there's a lot to this picture, right? We've talked about 2 different particles that we don't normally get measured, right? ApoB and the Lp(a). We talked about all these different lipoprotein particles and the fact that some of them are more atherogenic than LDL. It's just that there is so much more of LDL. That's why we measure it. And then we've talked about HDL and the fact that the level doesn't necessarily mean the function. That's a lot of cholesterol stuff that is involved here. It's not just about blood levels that we get as part of our yearly physical. I will tell you that I personally order an ApoB level and Lp(a) level on my patients. I don't care what their disease risk is. If you look at the AHA and ACC guidelines, they do not recommend that you just order them as part of a lipid panel for everybody, but I do because I want to know the whole picture. I want to know how many CABs there are. I want to know what is the genetic risk from this Lp(a). I need to put all of this into a big picture with the rest of the lipid profile so that I can help patients develop certain goals that they need and to figure out how to reduce risk. Once we have an idea of risk, then we can start to talk about how are we going to lower these lipids. A lot of you are not going to like this, but the fastest way to lower your lipids, mainly cholesterol, is with medications, specifically statins. Not only do we eat cholesterol, but our liver makes cholesterol. And in one of those steps, you can use statins to block the production of cholesterol. There are multiple studies that show the risk reduction with the use of statin use and the improved mortality from ASCVD with statins. I'm not going to argue that point. I will say that not everybody tolerates statins, so there are other medications that you can use that you kind of work through the algorithm of what to get to. But I also have a lot of patients who don't want to go on medications and they want to make lifestyle modifications. So we can do that as well. The two main lifestyle modifications come in the form of dietary interventions and exercise. There was a systematic review that came out in 2018 by the Journal of the American College of Cardiology. And in that, they looked at all the different diets that are out there and which ones would have the most positive effect on your lipid profile. The study demonstrated that LDL can be reduced anywhere from 30 to 40 milligrams per deciliter, which is a pretty big deal, from diets that are low in saturated fats, low in refined carbohydrates, rich in unsaturated fats and plant-based proteins, and that have a higher amount of nuts and that are high in fiber. The same study found that triglycerides can be reduced by replacing refined simple carbohydrates with whole grains and complex carbohydrates. Alcohol consumption also has an effect on triglyceride levels, so reduction in alcohol consumption will also lower triglycerides. ApoB is a little bit more complicated because it is influenced by both saturated fat intake and refined carbohydrates. So I can't tell you if you cut this one out, you can still take the other one and have a good ApoB level. The fact of the matter is you need to reduce saturated fats and refined simple carbohydrates in order to lower your ApoB. Another systematic review meta-analysis was actually published in January of 2025, and it looked at the effects of exercise on blood lipids. That paper found that aerobic and resistance training had a positive impact on lipids. It was able to reduce all 5 major lipid parameters, but the reductions were modest. They were all less than 10 milligrams per deciliter, and it didn't really do too much with triglycerides. It was more of the cholesterols. So the biggest bang for your buck for cholesterol and triglycerides are diet modifications, where you reduce your saturated fat intake and you reduce your refined simple carbohydrates. Replace those for whole grains. When it comes to Lp(a), there's nothing that will lower it. That's really fun news. So as of right now, there are no FDA-approved medications to reduce Lp(a). Now, there are monoclonal antibodies that are directed at a certain receptor called PCSK9. And those medications have demonstrated a dramatic lowering of LDL, and they can lower Lp(a) by about 25 to 30%, but they're only approved for lowering LDL. There are some emerging RNA-based therapies that show some promise, and they're currently undergoing phase 3 clinical trials. As of now, the only FDA-approved therapy to lower Lp(a) is a lipoprotein apheresis, which is a procedure. You go in and kind of get it taken out of your blood. But the data is very limited on whether doing this is going to reduce any cardiovascular events. When it comes to lifestyle modifications, again, nothing you can do. But I still think it's important to know about Lp(a) because it is very important to lower all the other risk factors for ASCVD when you have a high Lp(a), right? Like you got to control the things that you can control so that you can optimize your risk stratification. All right, friends, we are at the 30-minute mark. I'm going to give a brief summary of the things that we talked about when it comes to cholesterol and some of these particles. If you get it, you can be done right now, and I'm hoping you'll come back next week. If you don't get it, here's the summary. There is more to lipid risks and ASCVD beyond LDL and HDL. It just so happens we have a lot of LDL and we know a lot about LDL, and that's why we lean into it. But there are 4 other atherogenic lipoproteins. 3 of them, LDL, VLDL, and IDL, have to do with the triglyceride cholesterol ratio. The 4th one is a genetic thing. That's Lp(a). All 4 of those particles are packaged with apolipoprotein B, which is the analogy of the cabs that can drive around the triglyceride and cholesterol. HDL is packaged with apolipoprotein A, and it's involved in reversing the cholesterol deposition in our blood vessels, but we're not entirely sure if just because you have a high number, it means the HDL is functioning properly. Statins are a great medication to reduce cholesterol numbers. But if you don't want to go on statins, diet and exercise are also great ways to do it, namely decreasing your saturated fat intake, having unsaturated fats, decreasing your refined simple carbohydrates, increasing your whole grains and fiber. Exercise can also improve your lipid parameters, but it does so much more modestly than dietary interventions. When it comes to risk assessment, and setting goals, it's important to have all of these different lab values so that you have the whole lipid profile. Remember, this whole podcast started because somebody sent me a question because they were confused. And if there are more questions, you can go ahead and reach out. I typically don't respond to you directly because I am not your doctor and there is no doctor-patient relationship. But if there is enough confusion about it, I will make sure to put out some additional education so that we can all be on the same page of our understanding. Have a great rest of your week. I will talk to you next week. Thank you so much for joining me on this week's No Filter Doctor. If you enjoyed the content, you can follow me on social media. I'm on Instagram, Facebook, and YouTube. You can also go to www.thewholehumanhealthandwellbeing.com and sign up for the weekly newsletter, where you will get a link to the blog, that week's podcast, and a health tip of the week sent directly to you. It's important to know that while I am a doctor, I'm not your doctor. This podcast is for educational and informational purposes only, and it's not intended as medical advice. Listening to this podcast does not establish a doctor-patient relationship. The information discussed should not be used to diagnose, treat, or prevent any medical condition, nor should it replace individualized medical care. If you have questions or concerns about your health, please contact your own healthcare provider. Any decisions to delay or forego a medical evaluation or treatment based on the information discussed in this podcast are made so at your own risk. My only financial disclosure is my medical practice, The Whole Human Health and Wellbeing. Take care, and I'll talk to you next week.